Thank you so much for joining us today. It is May 22nd, 2025, and the time is noon. This training is hosted by the Ohio chapter of the American Academy of Pediatrics under the Parenting at Mealtime and Playtime program. In its 20th year of funding, Parenting at Mealtime and Playtime has provided evidence-based education to physicians, nurses, home visitors, community health workers, and beyond. This year, PMP will focus on adolescent health and supporting the providers that care for them. The Ohio AAP is excited to continue the work of PMP and looks forward to diversifying its audience and topics. If you have any ideas for the toolkit or mobile app throughout today's session, please share your ideas in the chat or reach out to me, Sahavi, the PMP Program Manager. We always appreciate feedback from our learners. Slides from today's session will be shared in a follow-up email. Thank you to our funder, the Ohio Department of Health, for funding this education session and supporting the health and wellness of children in Ohio. Next slide, please. The planners, faculty, and others in control of the content have no relevant financial relationships with ineligible companies. We have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is our intent to foster respect, belonging, support, and accountability with regard to the patients we serve. If you have any questions or comments, please contact Dr. Kelsey Logan at kelsey.logan@cchmc.org. With that, today's training is hosted by Dr. Stephen Cook and Dr. Roy Kim. Dr. Stephen Cook is the director for the Center for Healthy Weight and Nutrition at Nationwide Children's Hospital. He is also a professor of pediatrics at The Ohio State University Medical Center. He is a national leader in the pediatric obesity field, both in identifying cardiometabolic complications of obesity in youth, implementing family-based behavioral treatments of childhood obesity, and developing innovative approaches to implementing clinical models to treat childhood obesity. He served as an associate director of the AAP Institute for Healthy Childhood Weight from 2016 to 2019. He has led two of the largest primary care-based intervention studies in the U.S., respectively funded by the NIH and by PCORI. Dr. Roy Kim is a pediatric endocrinologist with Cleveland Clinic Children's. He's board certified in pediatrics and pediatric endocrinology and received his medical education at the University of North Carolina, Chapel Hill. He completed his residency at the Cleveland Clinic and fellowship at the Children's Hospital of Philadelphia. Thank you so much, Dr. Cook and Dr. Kim, for being with us today.
Thank you very much. So we're going to tag team this talk. I'll do the first half and Dr. Kim will do the second half. So we'll go to the next slide. Part of our discussion is going to look at identifying obesity and measures that we use. And this is a slide from the AAP's clinical practice guideline that I think helps us think of and hopefully gives us the idea that thinking of obesity as a chronic disease as something that we have to deal with over time, but to think of all the important factors that we have to address, not just exercise more and eat better, but thinking of cultural competence, thinking of shared decision making with families, identifying what other barriers might be part of families' experience with getting care, whether it's access, experiencing stigma, but also other social determinants and drivers to health. Next slide. Obesity is often an indicator of structural inequality. So remembering our social determinant factors that play into this. And while we may identify a child with a high weight and some medical comorbidities, if food insecurity and housing insecurity are bigger issues for the family, that's where we really do need to address our energies and working with our families. There are also genetic factors that play into weight. If anything, genes, not specific monogenetic anomalies, but our gene factors play into this in terms of 50 to 70% of weight, with environment contributing a lot, as well as early childhood experiences. So next slide. We talk about assessing weight and a little bit about how we use BMI. And in our next slide, one thing I'd like people to think about is asking and how to start the conversation about weight. So ask permission with families to discuss the patient's weight. And I like to use the term, instead of, your child has obesity, or if you use the word obesity, use it in a people first language. This is a child with obesity, not an obese child. I often will say something like patients with high weight, patients in a larger body, and then try to uh, get into the discussion of there may be medical complications related to high weight, and that's how we look at this. So using neutral language is more acceptable to families. And on the last bullet here is really there is offensive words and words that really turn families off. So even thinking of using the term overweight or obese, morbid obesity, obviously, or maybe not obviously, but should really be a term that is avoided. So next couple slides are just showing some growth curves. Really important to understand um, how growth curves are helpful, and we all look at these. But just to point out a few things here, this is a child's height growth curve on the right here, and on the next part of the slide um, is their weight curve. So one reassuring thing here is that the child's height is tracking along at or above their predicted height. And to me, that's very helpful because I don't think of metabolic uh, factors that are driving their excess weight. And if anything, it's more a sign that, they're gaining weight more rapidly. On the left is their weight growth curve, and you can see how they're having some crossing at a younger age. And of course, there's a big gap in the middle, probably from the pandemic where we weren't seeing this patient as much. The next slide should have their BMI curves. Yes. So this child is actually at the 96th percentile. And the next part of the slide that I want to show you is actually the extended BMI growth curve. So um, we use EPIC and a number of centers do, but the extended growth curves are very helpful because these dotted lines on here are percents above obesity. And this can really help us think of higher levels of weight. So obesity not only is a chronic disease, but it has levels of severity. So we think of stage 1 or class 1 obesity as 95th percentile to 120%. The next slide will show this a little better. I'm sorry, we'll go to that. So class 1 would be 95th to 120%. Class 2 is going to be 120% to 140%. And then class 3 being 140% and above. And simple ways to think of this is it's going to be close to class 2 being a BMI of 35, and class 3 close to a BMI of 40, definitely through later adolescence. So um, we will see kids in our center who run the spectrum of this, but far more of you are seeing kids who are right in the overweight and obese range. It's appropriate to try to provide lifestyle interventions there, but as further lectures will get into our discussions here, we need to consider, more intensive treatments with higher levels of obesity uh, that our patients experience. So I want to touch a little bit on the next couple slides on different tools to look at. There's a lot of discussion around here, and I think the short answer is that we really should stick to BMI at this point. I've done research early in my career looking at waist circumference, and we found some very interesting data that showed it actually had, in some large data sets, a bit of a higher predictive value and even waist to height ratio, similar to waist or weight to BMI. Weight to height is a BMI ratio, may be a better predictor, but we don't really have standardized norms or reference norms for kids. We have cutoffs for adults that we use, and there's been a lot of discussion around that, but we don't really have good values to look at next. There's DEXA scans, which is the image on the lower right. It's essentially, it looks like a flat scanner. You lay there and runs an X-ray up and down. These are clinically indicated for bone mineral density. We also will use them in our bariatric surgery patients to track bone mineral density, and we can look at it for body fat, but we don't really have great references to apply more broadly to kids. The middle picture of the gentleman in the white shirt standing on a scale is actually a bioimpedance analysis. This is a device that runs a current through the body and measures body water and can give you fat mass and muscle mass. This is a tool that we use in our center to track our patients who are going to more intensive interventions. And then skin folds are on the lower left, using calipers to measure skin fold thicknesses on the arms and along the body. These have been a gold standard for a long time in the nutrition science literature, but again, not something really useful for us in pediatrics. So a couple studies on the next couple slides looking at this. This slide is looking at waist to height ratio at a 95th percentile, or I'm sorry, at a 75th percentile and 95th percentile for boys on the top and for women on the bottom, and showing a really good area under the curve in terms of its ability to predict total fat mass. So if the reference you're looking at is total body fat, these higher values, 95th percentile, does seem to have some predictive value. I think we're struggling with the idea of both it's a tool that we don't have as great a reference yet, and how we truly clinically want to implicate or implement using it. Our next slide also looks at screening for percent body fat, um, and looking at different percentiles for the BMI. So if a BMI is at 97th or 98th percentile, you'll see the dark line here is a high fat mass index or a high percent body fat. And then we have two lines that'll appear here, I think. Next slide or next click. For boys at about 98th percentile, and then the next part is girls at 97th percentile, you're running into patients, if you think about it, in these higher BMI percentiles who have very high probability of having a high fat mass index or high percent body fat. So while we don't have any better tools, either technology-wise or anthropometrically, to apply in pediatrics, when we're getting patients in these high BMI percentile ranges, especially the class 2 and class 3, the vast majority of these individuals will have high percent body fat. So just to hopefully wrap up with the next slide here. Yes. Waist circumference and waist to height ratio may be a very simple tool to use, but we don't really have a good national standard. And I think the other thing that's important is while you want to be able to do it accurately, we also don't want it to be traumatizing to a patient. You know, our patients in a higher body weight, especially if they're in a stage 2 or class 2 level of obesity, we don't really need to add that to their experience. And these patients have already experienced trauma. The BIA, I like to say it's a gym culture tool. A number of name your gym like Planet Fitness or other places may have these types of tools, and people will use these. How we can apply this in kids, we're still looking at. There's some questions about validity, but for repeated measures of an individual, we're finding in our setting it's something useful, but it's not something we're recommending practices go out and buy. And then lastly, the DEXA scan, is a little bit more of a valid tool, but there is a radiation exposure, um, uh, as well as a cost that goes with this. And I think we have to ask ourselves, is this something that's going to be helpful above, um, a simple measure of height and weight and using our BMI percentiles and tracking that? Next slide. Yeah, so this is actually looking at national data of kids. It's the NHANES data set. And the colored columns are different levels of overweight to class 1, class 2, and class 3 obesity. So that 140% and above. If you look at that, kids in that range, having maybe 15 to 20% of those kids have some of these metabolic anomalies or metabolic abnormalities of high cholesterol, low HDL, systolic and diastolic blood pressure, maybe 10% of kids in that highest range, LDL, triglycerides being the highest, if you think about like 25 to 30%, and then elevated hemoglobin A1C anywhere from 5 to 10% of kids in that highest range. So the reverse is really important to think of. A child in the overweight range is not that likely to have abnormal fasting parameters or elevated blood pressures, and even in the class 1, it's not going to be very common. I say that because sometimes we'll say, well, we have to check their blood work, make sure nothing's wrong. Well, if a family is already skeptical or thinking their child's weight isn't a problem and they come back with normal blood work, they may not be that motivated to make any simple changes, even if it doesn't include weight loss. So last slide, or actually not last slide, last couple slides, just to review some things around BMI tracking. This is a BMI growth curve in a child, the standard growth curve, where it tops out at about a BMI of 32, as you can see. So when you use the extended growth curve, which is the next part here, you actually can see where this child's BMI is tracking up into the range of 50 to 60. And this is a patient that we actually follow and is being evaluated for actually metabolic surgery. Lastly, we want to touch on social determinants of health. Keeping in mind as primary care doctors, we look at this and we know this impacts many factors in the lives of our patients. Next slide. So the social ecologic model gets at these factors. You have the patient in the middle, the families around them, but then what's available, what's going on in the community, and what's going on in our society at large. So knowing that the built environment is very important around physical activity as well as access to healthy food, and looking at these social environmental factors, it plays into everything we do, and it plays into obesity as well. So next slide. Understanding that there's a number of non-biologic constructs that impact weight and excess weight. Race and ethnicity are factors, uh, as well as obesity and other comorbidities that arise related to the complex interaction of our DNA and our environment, the epigenetic environment, what moms experience when they're pregnant with a child, whether they're gaining too much weight, if they're sick, having hypertension or type 2 diabetes. All these will impact that fetus as an infant. And then what is their environment growing up as a young child and toddler or in early school age, if they're experiencing uh, adverse events like food access, poverty, domestic violence. These are things that expose them to, traumas that are metabolically uh, bad for them, for lack of a better term, in terms of how their body responds. And then once, perhaps having more access to food, we do see this, that people actually will go through weight gain and weight loss cycles with access to food, which actually just worsens our metabolism to be more susceptible to gain weight. So of the many factors listed on the next slide here, there's policy factors, neighborhood, family environment, and individual factors. These are from the AAP guidelines listing all the things that can be in here. And it's very overwhelming. And I think it's just important to think of when we're discussing this with families, there are factors that we, hopefully behaviors that we can change, but understanding what the environment is that they're trying to address it. The next slide highlights this, if we can look at that. So recognizing if it's an under-resourced community, there's not safe areas to play, access to public transportation, access to healthy food, areas that are safe to play. Street traffic is a big factor that has parents worried about their children going out to play. And over on the right there, ACEs. Children who have multiple ACEs, negative ACEs, and few positive ACEs have much worse emotional health as well as physical metabolic health. So last slide, last couple slides here. These are just some talking points of, again, from the AAP guidelines in terms of ways to discuss engaging the family. These are helpful to look at later when talking to the family here. And this is just some examples of maybe ways to phrase the opening discussion about a child's weight and looking at trying to make behavior change. And I think this next slide is my last one here. Yeah, so be aware of our implicit bias. We all have this, our staff has this, and understanding that little side comments are harmful, but even repeatedly bringing up things about someone's weight as a reason for their health problems is also going to be very negatively impacting the family, not just for the child, but for the parent as well. You're, in a sense, stigmatizing or shaming a parent in what they're trying to do for their child when they believe they're doing the best they can for their child, and yet telling them, your child's overweight. That, in a sense, they will look at that as a way to say, am I a bad parent? Using BMI really is going to be the standard tool that we use, and understanding the higher levels of BMI really is going to be good enough for us to use to identify excess body fat as one of the main drivers, as well as when to think of additional lab testing. Knowing the social determinants of health is important. Understanding what works in the context of a family. If it's parents that are separated and they're spending time between the two households, understanding, mom may be on board with things, dad isn't, trying to at least get dad on board with something, and setting up some consistent rules across, across the two households where the kids are spending time. That alone, even if it's not a huge behavior, may be very important to look at as a strategy. And asking for permission to discuss weight, to feel comfortable, have the family feel comfortable discussing this. And remember that, bullying and pushing and prodding and, kind of nudging our patients in all kinds of ways doesn't really have any evidence to support lifestyle behavior change in any area, and even less so around obesity. So I see one question in the box here, and we'll try to save those till the end. I'll keep an eye on it. And I will let Dr. Roy take over. Thanks.
All right. Thank you, Dr. Cook. And it's really an honor to be with everyone here today. And I am going to pick up the conversation on objectives 3 and 4, which refer to comorbidity screening. And then objective 4 is related to identifying obesity that has its roots in endocrine causes or genetic causes. And we are all on this call familiar with the complications of childhood obesity, but this figure illustrates the multi-system nature of this condition. And it really guides our approach to screening for comorbidities. Some of them will be less obvious and others will be much more obvious, but they can stem from very strong psychological component. Having severe obesity can lead to low self-esteem, be a nidus for being a victim of teasing and bullying. This can feed into and exacerbate cycles of depression and disordered eating. We will talk about cardiovascular risk factor screening using lab tests, physical deconditioning and low exercise tolerance is a very common comorbidity for obesity and can impede the adoption of healthy physical activity levels. We'll also talk about screening for fatty liver disease related to obesity, talk about endocrine screening, and then spend a little bit of time about often overlooked dimension of obesity affecting children, which is the musculoskeletal system, pain, and skeletal deformity. So the AAP guidelines that came out in early 2023, I can't believe it's already been 2 years since they came out, but they focus on some standard screening, and some of this can be laboratory based, some is from the history, some from the physical exam, and we'll go over each of these. Dr. Cook already showed a figure with a different representation for the prevalence of various comorbidities in children who have obesity. But you can see that dyslipidemia, which is the focus of this slide, is quite common in children who have obesity, especially high triglycerides. This pattern of low HDL, high triglycerides, and sometimes high LDL is also called combined or mixed hyperlipidemia, and there can be a strong family component to this, but also it's exacerbated by obesity. Fortunately, it usually doesn't reach a level needing pharmacotherapy, but it can, and it's often very amenable to lifestyle changes. So the AAP recommends that all children with obesity have screening for dyslipidemia, and at an age as early as age 2. Children who have overweight should be screened for dyslipidemia starting at age 10. So these are in general consistent with National Heart, Lung, and Blood Institute guidelines, which came out about 12 years ago, that stated that universal screening, regardless of BMI, should occur in children at 2 age groups, starting at age 9 and to be repeated at age 17, but to start earlier and be more frequent based on risk. And elevated BMI can be one of those risk factors, as can a family history of dyslipidemia, history of early coronary artery disease in a family, or some other conditions such as kidney disease, HIV, and other conditions, diabetes, for example. Abnormal glucose also increases in obesity, and the prevalence increases with obesity severity. Dr. Cook reviewed the thresholds for defining obesity severity as class 1, class 2, or class 3, and you can see that abnormal glucose is quite common. Usually this is manifested as impaired fasting glucose or impaired glucose tolerance rather than diabetes, but can reach into the upper 30% with the most severe category of obesity. And elevated hemoglobin A1C is less common, but still not that uncommon as obesity severity increases. Usually this is in the category of prediabetes, meaning A1C of between 5.7 and 6.4, with an A1C of 6.5 or higher being consistent with possible type 2 diabetes. Glucose screening, in contrast to lipid screening, is not universally recommended in children, but should be risk factor based. And the AAP and National Heart, Lung, and Blood Institute recommending screening for dysglycemia in children starting at age 10 in the overweight category if they have other risk factors besides being in the overweight category. And that can be a family history of type 2 diabetes, a history of polycystic ovarian syndrome, or the physical finding of acanthosis nigricans. And all children who meet the BMI threshold for obesity should have diabetes screening starting at age 10. This can be done with the hemoglobin A1C, diabetes range being 6.5 or higher, a fasting glucose, diabetes range being a glucose of 126 or higher, or much less frequently performed a 2-hour glucose tolerance test with a 2-hour glucose of 200 being part of the criteria for diabetes diagnosis. In terms of liver health, this is something that should also be screened for routinely in children who have obesity. The prevalence of abnormal liver enzymes in children with obesity is quite high. And it's important to note that professional organizations use a lower threshold to define elevated liver enzyme, citing a threshold of 22 rather than what's typical for a lab reference range, which could be 40. The ALT is recommended over the AST or GGT as it is more sensitive and specific. So you are fine just checking an ALT in your patients. We regard in our practice good sleep as fundamental to metabolic health. And so we do screen for disordered sleep in all children who are presenting for evaluation and care for obesity. The consensus recommendations stipulate we should be screening for symptoms of obstructive sleep apnea, and these can include snoring, daytime sleepiness, nocturnal enuresis, morning headaches, inattention. It could be frequent wake-ups throughout the night, gasping, snorting, all different kinds of abnormal breathing during sleep. And when these symptoms are present, polysomnogram or a sleep study should be ordered. Mental health screening is also extremely important in children with obesity or severe obesity. It is remarkable how common depression, anxiety, and disordered eating behaviors can be found. And we regard these as often factors that can contribute to the severity of obesity. They, to some extent, may also be the result of obesity. And this can turn into sort of a feed-forward cycle of low mental health and increased body weight and increased behaviors that promote weight gain or weight retention. So it's recommended for all children and adolescents with obesity to have an annual evaluation for depression using a validated self-report tool. Screening for bullying and teasing is also important. Many children who are the victims of this, who have obesity, decide to be homeschooled, for example, and that leads to less physical activity, more social isolation, and more lack of structure to their eating behaviors. We do routinely assess eating behaviors also, and we're looking for binging, restrictive behaviors that can also lead to binging, as well as purging behaviors. Emotional eating, eating in the absence of hunger, is a recognized type of eating behavior that can exacerbate obesity. Eating may also be done out of boredom, and also night eating and night eating syndrome. Musculoskeletal pain is quite common in children who have obesity. It can lead to kids not wanting to or being unable to participate in physical activity. There can also be structural skeletal deformity that occurs as a result of having a higher body habitus. This X-ray shows a child who developed blunt syndrome because of his so severe obesity and needed osteotomy and surgery to repair this in both of his knees. Moving on to identifying endocrine causes of obesity. This is often a question that parents have because they will say that their child doesn't eat that much and is physically active. And what is the hormonal cause for this child's obesity? And so as endocrinologists, we usually focus on these three hormonal situations: Cushing's disease or Cushing syndrome, hypothyroidism, or growth hormone deficiency. How we think about the likelihood of these endocrinopathies being present in a child with obesity often comes down to other accompanying findings on physical exam or on the review of systems. But you'll note for all of these endocrinopathies, poor linear growth is a common, almost universal feature for the still growing child. And all of these endocrine situations lead to low skeletal growth. Hypertension is very common, especially in Cushing's disease, and can also be found in hypothyroidism. Stretch marks, usually atrophic stretch marks, so these are due to thinning of the skin and are classically described as violaceous or deep purple in color, and also a dorsocervical fat pad, colloquially called a buffalo hump, and also a supraclavicular fat pad can often be found in Cushing's disease. But you should note that pink stria and fat pads such as these can also be found in sort of functional or generic obesity as well. So they're not highly specific. Cushing's is also characterized by having a lot of central fat accumulation and being characterized as having peripheral muscle wasting. So someone with very large trunk and thinner extremities due to low skeletal muscle would be a typical body habitus for Cushing's. Delayed puberty could be found in hypothyroidism or growth hormone deficiency, and then cold intolerance and constipation in hypothyroidism. So these growth charts illustrate a child who has an endocrine cause of obesity. And what you'll note in the child with an endocrine cause of obesity, in this case, Cushing syndrome, is that their linear growth starts off quite robust, but then over a span of several years, height percentile lines are crossed, and there is an early plateau of childhood growth. Meanwhile, weight gain continues unabated. This is in contrast to a child with functional obesity or polygenic obesity, wherein they have quite robust linear growth, as well as sort of weight gain that is out of proportion to their height gain, resulting in elevated BMI and obesity. And this phenomenon of children with functional obesity being relatively tall is quite common and thought to be due to a general effect of overnutrition. Cushing syndrome in children is characterized by usually a high prevalence of accompanying features besides weight gain and obesity. We see, as we've discussed several times now, growth retardation is usually observed. There can be menstrual irregularities in females. There can be other skin changes such as hirsutism, the atrophic stria, acne. Hypertension is also relatively common, and fatigue and low energy. How do we screen for these endocrine causes of obesity? For Cushing syndrome, the test I most commonly use is a midnight salivary cortisol. So as you'll recall, cortisol is secreted in a circadian pattern with a big peak at 8 a.m. and then a gradual decrease over the course of the day. And it's very low, usually at midnight. So having a child collect a saliva sample at midnight, bringing it to the lab next day, this has a high sensitivity to rule out Cushing's syndrome and Cushing's disease. But you should keep in mind if a child's sleep cycle is disrupted, then their circadian pattern may result in their cortisol nadir occurring at a different time other than midnight. So you should keep that in mind. So if there's any question, we do often use these other cortisol tests, including a 1 milligram dexamethasone suppression test, where a tablet is given at bedtime the night before, and an 8 a.m. cortisol is checked the next day, and that cortisol should be low if they're appropriately suppressing, and if it's not suppressing, that could be a sign of uncontrolled cortisol secretion. The thyroid is quite easy to screen for with a TSH and free T4, and if abnormal or if there's a goiter, thyroid antibodies could also be added. And if there is poor linear growth deceleration, or an adult height that is predicted to be below genetic expectation, we will screen for growth hormone deficiency with an insulin-like growth factor 1 and a insulin-like growth factor binding protein 3. If those are abnormal and growth continues to be slow, a growth hormone stimulation test can be done. Moving on to a conversation about syndromic and genetic causes of obesity. Some generally observed features in these situations is that the obesity that a child develops tends to be very severe and tends to develop early in life, usually by age 3 or 4. They're usually characterized by hyperphagia, so very high appetite, difficulty getting full from a meal, and once full, having a quick return of hunger after the conclusion of a meal. So these children are often fixated on when the next meal, when the next snack is, and not being away from food for very long. Developmental delay is a common feature of syndromic obesity. There are often also birth differences or anomalies, such as postaxial polydactyly, meaning extra digit on the pinky or ulnar side of the hand, congenital heart disease, kidney anomalies, eye disorders, and impaired hearing. Prader-Willi syndrome is the most common form of syndromic obesity. These children almost universally have very low muscle tone in infancy and therefore poor feeding. It's not uncommon for them to need a feeding tube, in fact. And then at about age 4 or 5, it's like a switch flips. And instead of having poor feeding, the children are very voracious feeders and exhibit hyperphagia. They may also have other features such as hypogonadism. They may develop growth hormone deficiency, central hypothyroidism, or central adrenal insufficiency, and they may have some physical findings, such as in this child, this sort of bitemporal narrowing here up in the forehead, thin upper lip. They may also have small hands and feet, or almond-shaped eyes are also described in Prader-Willi syndrome, and light-colored hair too, but it can also be quite subtle. Children with Prader-Willi syndrome may have speech and motor delay, and sometimes exhibit other behaviors like skin picking or have autism-related features. And there are specific genetic tests that can be done when Prader-Willi syndrome is a concern. This table just highlights a few other syndromic and monogenic causes of obesity besides Prader-Willi, which we talked about. A condition called Bardet-Biedl syndrome is gaining interest because there is now a medication that can be used to treat this. These children have severe early onset obesity. Maybe around age 6 to 8 can be identified as having rod cone dystrophy, which may manifest as vision impairment, especially early nighttime vision impairment. They may have some developmental delays and may be born with an extra digit. Children who have a BDNF mutation may have obesity and autistic features. Leptin deficiency is quite rare in humans, but can be accompanied, their obesity can be accompanied by hypogonadism or delayed puberty, or micropenis in a male, in addition to very marked hyperphagia. Alström syndrome is characterized by having, again, the cone rod dystrophy, high prevalence of type 2 diabetes. In contrast to many of the other syndromes, people who have Alström syndrome often have a normal IQ and they can develop cardiomyopathy. So in summary, comorbidity screening for children with obesity is important to do. It's recommended, and it can be guided by family history and can be done by using lab work and your physical exam. The observation of slow linear growth in a child could suggest an endocrine cause for obesity. And lastly, genetic forms of obesity tend to be very severe and have early onset. There may be congenital anomalies or other features that can serve as red flags, such as developmental delay, hearing impairment, vision impairment. And if you see those features, then consider having a genetics consult for your affected patient. And that concludes our presentation. I think, so Javi, we have time now for questions.
Yeah, we have about 10 or 12 minutes for questions. So if you want to unmute, you are more than welcome to do so and ask the questions, or you can use the chat, and we'll give it a couple of minutes for questions to roll in.
I have a question for you. Just from an observation, I spend some time each year in Guatemala working in an underserved community where there's a very high level of childhood growth stunting in kids under the age of 5 just because of malnourishment. But there's also an inordinately high rate of diabetes in their mothers who are in their 20s and 30s, which I was wondering if you could comment about, would this be an example of some of the epigenetic factors that lead to that we should be watching for in kids who have obesity, like later in childhood? I've always wondered about that disparity between the skinny malnourished child and obese diabetic mothers, but wondering if there could be a connection that explains that more.
Yeah, there's been multiple studies and observational studies that have looked at this and shown this. One of the tragically important study was the Dutch famine study, was data from World War II, where they actually were able to track the records from the Germans who were imposing food restrictions on families and had detailed records, so they knew that women who were pregnant during that period of time, how many calories they were being provided, and showing that women who had malnourishment during pregnancy in the first, second, third trimester, their children, their offspring, had higher rates of obesity, higher rates of type 2 diabetes. There were some differences depending if it was first or second trimester, and that led to the part of the concept of the Barker hypothesis that, a small for gestational age child is at higher risk for this fat accumulation. And a simple way I try to describe it to students and trainees is, if you think about it, a child is surviving a stressful in utero environment, like mom's a smoker. And in order to do that, they probably have to be very fuel efficient. And then once they have access to food and calories, they're going to store it. They're more likely to store it and store it in very abnormal ways. Not all fat tissue is the same. Fat around the middle, especially if it's visceral, will be metabolically different than if it's subcutaneous on the arms, hips, and thighs. So there's a lot into that, but it's definitely that impact. I think the closest thing I've seen in my career is families who in the first generation come to America. The parents were raised in another country. They come here and their children are exposed to American culture and diet and are having higher rates of weight gain and obesity than their parents. So it's definitely a component of that, and it's really tragic because we're trying to strike the right balance. On the flip side, moms who gain too much weight during pregnancy are also at those children are at elevated risk for obesity and cardiovascular risk factors. I don't know if there's anything else you want to add to that, Roy.
Yeah, the the concept of the epigenetic changes has really been borne out too in animal models where they induce uterine and placental insufficiency during gestation. There are certain changes to the tags on the DNA in the offspring that in turn can affect their own health lifelong, but then also subsequently their offspring. So it can really be a generational phenomenon that results from, sometimes a narrow period of nutritional deprivation for a mom. So it really highlights the importance of having good nutrition for pregnant mothers and then also for infants in that newborn period. These babies who are born small, sometimes they gain weight too quickly, and that can also induce a later risk in life for type 2 diabetes. So it just highlights the need for good nutrition for expectant mothers and their newborns.
Thank you both. I see Dr. Cook just responded to the question in the chat, but Dr. Romano asked, what role do ultra-processed foods play in obesity of children? Dr. Cook said, ultra-processed foods are one of many environmental factors that worsen risk for excess weight gain, just like more screen time, lack of outdoor play, etc. I was just curious if either of you wanted to expand on that a little bit more.
Yeah, I mean, obesity. It's really important to understand that it is not one phenotype. There are so many factors that play into excess weight gain. And just like there's a new diet every other month, there's a new risk factor for obesity. And the reality is that there's many, many risk factors. To comment on Roy's slides about the genetic obesity, even when we see kids in that young age, real severe obesity, hyperphagia, developmental delays, I think it's maybe 1 in 20, 1 in 35 or something like that might have one of these rare genetic type of causes of their obesity. And so the reality is there's not going to be 1 or 2 factors that you can put your finger on that will drive it. I mean, there are behaviors that you can change. So shifting away from processed foods and fast foods and takeout, getting families into more structured meal plans, may sound like 1 or 2 simple things to do, but by no means are simple tasks. So trying to find where these factors, what are behaviors that can be changed will be really key.
Yeah, I would add about ultra-processed foods in particular. It is often, those are characterized by often high fat, high added sugars, low fiber, low nutritional density from the standpoint of micronutrients. And so that in and of itself can increase energy intake, as well as be related to low satiety and quick return of hunger, and probably also influences the microbiome, our intestinal flora that has such an important role in our insulin and glucose metabolism. So it's probably at multiple levels. And, like in our practice, we don't specifically screen for that except to say, what kind of foods are you eating and where are you getting it? But we have to recognize also that convenience foods can sometimes play an important role for families too, if they don't have time or the skills or access to make their own food. So we try to adapt our recommendations to people's particular situations and help them make healthier choices if they do need prepackaged foods.
Yeah, it's really important to find, with any of these findings, if we can find the one simple bullet point that can go through and ring a bell with a family, sometimes that's, all we can hope for. The analogy I've started to use a lot is saying, the food industry is like the tobacco industry was 20 years ago. They're trying to sell that this is all safe and all good for you, and they're really out just to take your money. And that will at least resonate with families. And we try to point out, no, I get it, you got to kind of grab what you can with schedules, but if you're getting fast food, don't supersize, don't get get a water, get a milk instead of a sugary beverage, and trying to, make some cuts around the edges there instead of eliminate it entirely. So it's really important that we can be able to digest quick facts out there and spit them back to families in ways that are truthful and understandable. and the food industry is just not our friend.
We probably have time for about one more question. All right, I am hearing none and seeing none in the chat. Thank you all so much for your participation today. And thank you so much, Dr. Cook and Dr. Kim, for facilitating such a great training. And thank you, everybody, for your participation and attendance. Please go ahead and check your email to claim your CME and MOC credit. I'll be sending it in just a few minutes. We ask that all participants complete the short survey, even if you do not plan to claim credit. This will enable us to collect endpoint data to measure the rigor of our programming. Once you complete the survey, you will receive a certificate within 10 days. I will follow up with these directions again via email for your reference, and you will also find the slide deck from today's session included. And next slide, please. If you have any questions or suggestions for PMP programming, please call or email me at the contact information listed here. This concludes today's training session. Thank you all for your time and energy, and I hope to see you in another Ohio AAP training.